moving forward to other types of cancer requires initially the identification of targets on those cancer cells that can be safely, antigens on those tumor cells that can be safely targeted. There may not be that many of them on solid tumors that would be ideal, but you need to select for the most optimal ones. Then you need to consider what goes on in a solid tumor that may not go on in the bone marrow of patients with leukemia, which and that's referred to as the tumor microenvironment, which is a concept that is relatively new in the field of tumor immunology. But it's very clear that the tumor is able to recruit immune suppressive cells and factors that could inhibit the efficacy of CARModified T cells. And that would include such cells as regulatory T cells that suppress effector T cells, myeloid-derived suppressor cells, tumor-associated macrophages, cytokines such as TGF-beta and IL-10, and expression of ligands such as PD-L1 and CTLA-4. All of these can conspire to inhibit the activation of the T cell and the ability of the T cell to kill the tumor cell. And so the first is to identify proper targets for solid tumors, and that's one issue. The second is to overcome this hostile microenvironment. So you need to build a better T cell. And that can be done through additional genetic modification or perhaps selection of subpopulations of T cells that are capable of overcoming that tumor microenvironment. And then the third step, really, I think it becomes important, is to develop clinically relevant mouse models before you inject this into humans. You're playing with fire with these immune cells that are genetically modified, and so you need to appreciate that, and you need to be very careful not to rush this technology into patients and first fully evaluate them in responsible and interpretable mouse models to know that what you're going to do, as best as you can tell, will be safe for the patient.